The one on the left is for the left side and one to the right for the right ear. So I'm just going to correct myself. The one on the left is for the right ear and the dome on the right,
Hi everyone, this is Mr. Neil Reiteter, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a very interesting case of a patient who attended unknowingly with both ears blocked with a lodged hearing aid dome. As the video is being shown, I'm going to just discuss with you the case history, the background. So I actually started with the patient's right ear when the patient attended, but for the purposes of this actual video, I'm showing you their left ear first. And the patient has what we call a power dome lodged in her ear. So initially, the patient had what we call a sound tube hearing aid. So a sound tube hearing aid consists of behind the ear hearing aid. So the main body of the hearing aid is positioned behind your ear. And attached to that is a thin hollow tube which travels down the front part of your ear and then goes into your ear canal. And attached to the end of that thin hollow tube is a dome of a various shape and size and configuration. So this patient has got what we call a power dome. It's a dome that's designed to create a complete seal in the ear. And what's happened is this dome has detached itself from the hearing aid and remained lodged in the ear. But what's very, very confusing is that this patient, because she was struggling with these domes, she went back to the NHS and asked whether she could go back to the more traditional type of hearing aids, which is where you have an earpiece, a mould that's designed for your ear. So an impression is taken of your ear, and then from that a mould is made, and the mould is attached to the hearing aid via a thick tube. So this patient's been wearing this more traditional type of hearing aid with a mould fixture for the best part of 6 months now, which I've struggled to get my head around, because in order for her audiologist to make this hearing aid, they would need to take an impression of the ear. And if you take an impression of the ear, surely you're going to see this dome. And that's why I can't fathom, because the patient said that since she's had the new hearing aids with the molds, she's not worn the old ones. In fact, she doesn't own the old ones anymore, because that's returned to the NHS. So I was just a bit confused as to how this has gone unnoticed. So obviously you've got to take, I'm not for one moment saying the patient's not giving the full story, but as an audiologist, I just can't understand, and maybe the patient's completely right, the audiologist has just ignored this. So this patient attended with severe excruciating earache on both sides. This is the better ear, the left side. The right ear was even worse. And you can understand why. She's got this dome, and this dome is, you'll see the end still image, but it's a dome that's almost designed to create a vacuum. So it's to create an acoustic seal all the way around. And this dome is actually a bit smaller than it should be for the patient's ear, and that's possibly a reason why it's got trapped. So as the patient was trying to remove the dome and the hearing aid from her ear, this dome just got lodged because it's really tightly fitting. And on top of that, the patient's been wearing her current energy. She came in today wearing her normal hearing aids in her ear, with the ear molds, and obviously they're going to go in the ear. So this is extremely large, and she was in extreme excruciating pain. She couldn't hear a thing, and fortunately, the patient's daughter was in attendance as well to help with the communication, and the daughter was actually watching this, and she was just shocked that the dome was in there. And the problem is, the patient's already in pain, and then trying to remove this dome. Every time I touch this dome, it's just because it's so painful for the patient. And unfortunately, audiologists in the UK, we're not licensed, we're not trained to prescribe any local anaesthesia. So, for example, lidocaine. As an audiologist, we're not allowed to apply this in the ear, and as an audiologist, we're also not. We don't give topical local anaesthesia or obviously perform general anaesthetic procedures. I managed to get that out in the end, and I used to use a combination of instruments. Eventually, I used a standard St. Bart's ear hook, but for a period of the procedure, I tried using forceps, but I couldn't get the forceps in and underneath the dome because it was touching the canal wall, and the patient found that uncomfortable. I also used a Cawthorne hook, which is that metal instrument, trying to get into the centre of that dome to pull it out. Now, I've removed the dome, but you can see the patient's got an ear infection. They've got otitis externa, and so there's a lot of debris here. Now, what we discovered was, although the patient still got a hearing loss and they still need to wear hearing aids, because they've been so hard of hearing for such a long time with those domes in the ears. Remember, those domes are like, it's like a large piece of cotton wool in your ear that's completely sealing your ear. It's causing a hearing loss because sound couldn't get through the dome. And suddenly, because I removed that dome, her ears became very sensitive to sound. So you will see on a few occasions the patient, especially on the right side, the first ear, the patient was jumping a bit because the noise from the suction, she was just taken aback by it because she wasn't used to hearing anything, even with the hearing aids. And suddenly she's hearing all this suction noise. And so we just have to have a steady hand here. And fortunately, the patient's, as I said, daughter was in attendance and she was supporting the patient, keeping her calm and trying to keep her still as possible. Now, we've written to the GP, they're going to need some antibiotic ointments, hopefully a spray. What I'm trying to do now is just mop up as much as I can. I'm not going to get every little speck of this out. It's just to clear as much as we can as safely as possible without causing any distress to the patient, who was already under a huge amount of distress. So we're just on the eardrum here. I'm just trying to suction some of this discharge off the drum. You can see there. And the ear is very damp, it's very sweaty, it's very humid because of this dome. It's created those conditions within the ear. I can see the hammer bone there. There's a bit of a retraction of the eardrum. And I just want to hover over. I'm just a bit wary whilst I'm suctioning this because the patient wasn't steady, and understandably so. I was just worried about any sudden head movements, and any sudden head movements would mean that this suction probe would touch the canal wall and potentially graze and cut it and bruise it, and we don't want that. So whilst I was performing this, I was half preparing to withdraw the instruments. I was just getting ready for any sudden movements to come out the ear. So already the patient could hear significantly better, so I think I'm just going to mop up the tin even a bit more, and I'm happy with this, especially considering where we were. Now, there was a phase during the first ear, which you're going to see in a moment, where I advised the patient and their daughter that there might just be better, and I was going to refund them so they can put the money towards seeing a private ENT, because it was just so painful, the right side. Even just you'll see in a moment when I was making just the minimum amount of contact, that it was so painful for her. I said at least an ENT would be able to inject some topical local anaesthesia, and in the worst case scenario, I've done a general, but we did manage somehow to remove this. So this is the right ear. This is the one that was really uncomfortable for the patient. And this dome, for me, appeared to be in the ear a lot longer because it was more, or maybe the ear was just more naturally waxy. That's probably the reason why. But this dome has discolored a lot more than the left ear. And again, this dome is oversized. That is the problem. This is why it got trapped in the ear. This dome is too large for the ear. The thing with these domes for hearing aids, for some people they fit brilliantly, but they're not custom made. So there's some patients whereby these domes, they come in 3 different sizes typically, small, medium, large, but none of the sizes are just quite right for some people, and that's because everyone's ears are different, they have such a unique anatomy. So the patient's now got custom molds, which is obviously exactly what she needs, but this was so lodged that and it's been there for such a long time. You'll see in a minute, this silicone is beginning to degrade within the ear. In a moment, I'm going to use a hook trying to lift this off the canal wall, and the silicone here was just breaking up into little pieces. So what I'm looking at there is the centre of the hole, and this is the part where I actually invited the patient's daughter to come over so she can actually see, because just so I could show them what was going on. So what I'm trying to do here with the sucker is just trying to clear some of this wax that's kind of embedded itself onto this dome, just so I can visualise the dome a bit better. And I'm actually looking for something that I can use forceps to grab onto. But with this type of dome, there's nothing I can actually use the forceps to grab onto other than the flap that's against the canal wall. And you can see here at the bottom, this flap, and I'm just teasing this. I just want to see if it comes away easy, but it's not. It's attached itself to the canal wall. So I think I'm going to use a hook in a moment, and I'm going to try and get underneath and lift it. But you can see it's breaking away into little pieces. And the patient was actually finding that really uncomfortable. I think in a moment I'm going to use the Cawthorn hook. So it's not often that I need to use the Cawthorn hook. It will be in a minute. So again, I'm trying to get the St. Bart's ear hook into the middle here. And I've managed to get it in, but as I'm pulling away, it's so uncomfortable for the patient, and I had to just come out the ear. And I think it was at that stage where I mentioned to the patient and the daughter that they might just benefit from possibly seeing an ENT locally. Because on the NHS, the waiting list at the moment, it's 12 to 18 months. So they would need to, obviously, if they wanted this to remove, to go privately. And it can be expensive, obviously, when you see ENT. Just got so many overheads. And if they're going to inject some local anaesthetic, that's going to cost a lot more. So I was more than happy to, obviously, refund the patient so they can put that money towards seeing an ENT. So I'm just using the forceps here. I'm trying to get underneath. Now, I was able to do it on this side. And I've just grabbed onto it and I've just pulled it out. So this is the moment where, so remember I did this here first when I went to which actually attended, and you'll see in a minute the patient will jump because of the noise, because it's just so shocking for them, and I just reduced straight away. So we just calmed the patient down, and she was obviously just getting used to hearing again. And the daughter was great, really helped. So I'm just trying to get this blob out. This is really impacted. Now again, I'm not going to get every little speck out. I just want, again, the patient is very twitchy. I just want to get as much debris out as I can as possible. Now, what's great now, I've cleared the passage there. There's a gap towards the eardrum. You can see the eardrum in the distance. So already the hearing's much improved. I'm just using the fine end suction probe now so I can, it's a bit quieter for the patient. So again, I can see the eardrum there. It is a bit inflamed. You can see it's a bit bulged, it's a bit bruised. But at least we can, the eardrum can see daylight now, which is, previously it wasn't able to. I'm just trying to peel as much away. This is just dead skin now. It was clarinetting a bit, and it was getting, at moments, a bit loud for the patient, so we just had to be careful. So you can see this here, although it's not infected like the other side, there was no discharge, it's just a bit more tender, it's a bit more inflamed, it's a bit more angry. So just being, so you can see how cautious I'm being there. So it's just a bit more, this is near the entrance, so I can put a bit more pressure here. And you can see to the right, this is where it's really painful for the patient. And actually, in a moment, there's going to be some flesh that I suctioned out. So that dome had caused so much trauma and compression that is actually exposing the bone of the ear canal, and the skin that was normally lines the ear canal it was dead, it was ruptured, it was like an ulcer there, and some flesh came away. See in a moment, just here. So part of this is fresh dead. This is just dead skin that had just been traumatized, and actually ended up suctioning it out, I think. Or a bit of it did come out. So I decided to end it at that stage. I was happy I could see the eardrum. I didn't want to cause the patient any more discomfort. There's the dome.